So good afternoon, everyone. It's our final session of the 2022 Children's Week virtual conference. If you have attended multiple sessions this week, thank you for sticking with us. If this is your first session, welcome. I'm glad that you were able to join us for this session. I'm Dr. Ruth Adibuya, the Managing Director for the Stanford Center for Continuing Medical Education, and I'll just be here to provide a brief introduction. First, this session awards CME and ANCC credits. You'll receive an email from the Stanford CME office on Monday with instructions on how you can avail of those credits if you are interested. Throughout today's session, please use the Q&A button at the bottom of your Zoom screen to send questions to our speaker. This afternoon session is on common reasons for acute pain consultations, and I am pleased to have Dr. Genevieve D'Souza as our speaker for this session. Dr. D'Souza is a clinical associate professor of anesthesiology, perioperative, and pain medicine, and is the director of the Pediatric Anesthesia Resource Center here at Stanford University. She's board certified in pain medicine as well as pediatric anesthesia, and is trained in medical acupuncture. Thank you so much for being here, Dr. D'Souza, and I'll turn it over to you for our presentation.
Thank you so much for the kind introduction. Thank you so much. It's a great pleasure to be here. And to end out our series this week. It's been awesome to listen in on these awesome presentations this week. And I love to be here. Thank you so much to Dr. Adibuya and for coordinating all these and for this invitation. And today I'm going to talk to you about something that I'm very passionate about. And as a member of the pediatric pain management team here at Stanford Children's Health, I want to talk about the common reasons for acute pain consultations. And some of my objectives at the conclusion of this activity, I want to explain the importance of developmental context in the treatment of acute pain, how to prevent chronic pain and management of some chronic pain conditions, and also assess the pharmacologic and non-pharmacologic pain management strategies that we design for specific pain conditions seen commonly for inpatient acute pain consults here. I want to state that I have no disclosures or conflict of interest in this presentation. The International Society for the Study of Pain had initially in 1979 come up with a definition of pain as an unpleasant sensory or emotional experience associated with actual or potential tissue damage or described in terms of such damage. Now, if you look at this definition, it was kind of a little vague. There has to be an actual or potential tissue damage or described in terms of such damage. So it doesn't account for those patients where there's no visual tissue damage. And this had to then be revised to account for those patients who have nerve or neuropathic pain damage where you cannot identify a source for damage, right? So in 2020, ISP revised this definition and added the words resembling that associated with actual or potential tissue damage. And this allowed that for those with patients who are nonverbal or to be assessed using other validated indicators. And this highlighted those many pain conditions such as neuropathic or nociplastic pain for individuals that may report pain in the absence of clinically detectable tissue injury. And this can be prevalent in individuals and children as well as adults. And it decreased the emphasis of pain associated with tissue damage, which allowed nonverbal adults and children to allow better definition of pain, which was a big landmark for pain definition. Pain is always a personal experience, and that is influenced by varying degrees by biological, psychological, and social factors. I like to say that my favorite researcher is Clifford Wolff, And how would you define pain? It's so difficult to define pain. And I love to quote this article. What is this thing called pain? And how would you define it? And so what is this thing called pain is an article I would ask you all to read. And in that, he describes pain into 4 different categories called nociceptive, inflammatory pain, pathological pain. And pathological pain itself can be divided into subgroups as neuropathic and dysfunctional pain. And so if you have this patient who comes up to you and says, I have pain, and it's very easy. If there's a surgical cut, and you can say, okay, there was a fire and there's a red signal, there's fire, so there's a fire, and so there was smoke and you had to evacuate. So that's your nociceptive pain. The inflammatory pain was, there was fire and the fire is wiped out, but there's still smoke. And so your signals in your brain were telling you that you had to evacuate. So that's your inflammatory pain. And what's your pathological pain? Maybe there was fire a long time ago. Maybe there was smoke a long time ago, but the signals in your brain are still going for it. And that's your neuropathic pain or your dysfunctional pain. Maybe there was something, but the brain signals are now misfiring. And that's where the pathological pain comes from. And that's the neuropathic pain or the dysfunctional pain. And that's well described in this paper from What is this thing called pain. In the acute pain setting, what we do see in the hospital, it can be also categorized as acute to chronic, including procedural, breakthrough, visceral from a disease process, post-operative, and commonly we also see from acute exacerbation from conditions like headaches. Again, every pain experience is unique and varies across age and stage of development. And why is this so important that we attack and treat this pain at every presentation to the hospital? Because prolonged repeated exposure to high acute pain intensity or frequent exposure to pain as influenced by stress, illness severity, and previous pain experience can impact your response in the short and long term. Even a child who comes to the hospital for immunizations, and if you don't treat this fear of immunization or the pain of immunization, every subsequent exposure to the hospital can prolong this child's pain experience. And even young adults or older adults can have fear of needles. We very frequently hear, even in our own practice, we hear of young adults who fear of going to the dentist because they fear of needles, which comes from having this irrational fear of immunizations as children because they were never taken seriously, that they were scared of immunizations. And so early procedural pain is associated with regionally specific alterations in thalamic development. And this is well described in the 2 papers that are listed in this study below. And to further prove this, neuroimaging studies of newborn infants and adults have shown that when you have frequent exposures to pain impulses, the brain volume in these extreme preterm babies, so preterm babies who stay in the ICU, there are studies out there that prove that a preterm baby could have painful experiences on an average day in the ICU. They could have exposure to pain about 18 to 30 times in a day. So even her heel stick for glucose, having thermometer stuck in their axilla or in their rectum or in their mouth, being swaddled and then being unswaddled for diaper changes or IV sticks. There are multiple such exposures to which for us as adults doesn't seem that painful, but this baby who's now swaddled and calm and sleeping is suddenly woken up for vital sign check, or to have their temperature checked, or is getting a heel stick. And so they get this startled response. And every such impulse is now considered to be a pain impulse. And under 28 weeks, their response to pain is actually an inhibitory response where their heart rate goes down. And we can't tell whether they are in pain or they're not. But these responses then have an impact on their brain development. And these studies show that they have brain region volume. The brains actually don't develop as much as a normal, regular full-term infant. And the studies that is listed in this Dr. Walker's study shows that they have a smaller brain volume than a normal full-term infant, which is important to know that exposure to multiple painful procedures or stressors does have an impact on these infants in the long term. You do need higher caregiver sensitivity and greater soothing during this infant's 2-month vaccinations, or higher levels of preschooler avoidance and lower levels of ambivalence. And you want to subsequently, at every exposure of these children, you want to give them greater sensitivity. We call it no needless pain. Even at LPCH, we have gone through so many encounters. We have gone through the Buzzy, ouch list. We have a pain plan that's listed right when they come into the hospital on how these children want their pain treated. We ask the parent. We want older children should be allowed to communicate their pain plan. And why is this important? Because every time they come in, if their pain is not adequately addressed, this will impact how they feel at their subsequent exposure. And I've had this personal experience because I had this a picture of my infant who was in the NICU for neck for 7 days. And unfortunately, for up to 2 years, every time she went in for her immunizations, she was always scared, and I never figured it out why, which I think was similar to this because she was so scared. She did have a memory, an infant memory of being in the ICU, being stuck multiple times for heel sticks and for IV sticks. It has all normalized now, and she's a healthy teenager, but at that time, it did impact her. In older children, the PICU experience, which is worsened by the illness severity and the exposure, it doesn't have the long-term experience of lasting for years, but it does allow some amount of post-traumatic stress disorder, but can last up to 6 months. So it does impact them in the short term, but doesn't last as long as it does for the infants. So why is pain so important to be treated even in the hospital setting? Because if your acute pain morphs into chronic pain, it can cause societal costs for caring for children with pain can be up to 19.5 billion annually just in the United States, as per the pain report published in 2016. So here's a picture of a pain management team at Stanford Children's. And this was a picture taken from our retreat in 2020, just before we went into the pandemic. So as you can see, we have a well-established team. It involves pediatric pain physicians. We have psychologists. Our team in the outpatient setting does involve rehab, physical therapist, occupational therapist. Our inpatient team of the pain management service consists of pain management physician, advanced pain nurse practitioners, and when appropriate, a licensed child psychologist. We did have a massage therapist that used to round with us, but right now with COVID restrictions, the massage therapist is no longer with us. Hopefully, at some point, the hospital will allow them back. The inpatient pain management team provides pain and symptom management 24/7 for expert consultation for hospitalized patients experiencing pain associated with a variety of illnesses and treatments. And this pain could be following illness, surgery, for acute hospitalizations, for cancer, sickle cell, for long-term management of acute exacerbation of rheumatoid illnesses, for GI illnesses, for nausea, itching, for unknown symptoms where no one has figured out what is wrong. They call us. We are sometimes like the Ghostbusters for the hospital, for anxiety and stress due to hospitalization, and for weaning management for long-term management. And we also get acupuncture consults. When we, about 10 years ago, when we had Carly the dog on our service, we used to get Carly consults too. We no longer have the dog on our service. In the inpatient setting, we do have a service dog on the outpatient clinic setting. And so we did an audit just for this lecture on the consults for acute pain consults for May 2020, which included 18 weekdays. And as you can see, our service is busy on an average month. We go with ebbs and flows. Some weeks we're extremely busy, depending on how many surgeries are in the operating room and what's with the school and school breaks and summer vacations and how parent schedules line up and what illnesses are out there, what respiratory illnesses are out there. So in May, we were quite busy with a number of scoliosis surgeries, tumor excisions, hip dysplasias. We had NUS procedures going on, spontaneous pneumothorax, abdominal surgeries, urologies. And as you can see, these are just the long-term admissions. We had some consults for post-dural puncture headaches, functional neurologic disorder, sickle cell, neuropathic pain. And we had some acute exacerbation for chronic pain. And these are patients that we are consulted on who have stayed in the hospital for long, who are in the hospital for other conditions. Typically, they are admitted on the medical side. Some are in the ICU and some are on the medical services. And this is an average of, on a typical month, including other hospitals. We divide these consults into 3 buckets. We have acute pain consults, we have the cancer pain consults, and then we have acute on chronic pain consults. So we have perioperative pain, trauma-related pain, other acute pains, the functional neurological disorders. We have tumor-related pains, and then the therapy-related pains to cancer. And then we have acute on chronic pain admissions. I'll talk a little bit about enhanced recovery after surgery versus perioperative surgical homes before I go to individual acute pain consults and how we manage them. So recently we've gone into the perioperative surgical home in the past, since the past 3 years or so, which is a patient-centered and physician-led multidisciplinary team-based approach of coordinated care that guides. It's an individual patient-based approach that guides the patient's care right from before admission and leads decision-making up to patient's discharge and beyond. So it involves prehab, where it starts right when the case is booked, where the surgeon looks at the patient, decides what else needs to be done to make sure this patient has the best experience ever. So he may consult the anesthesiology service and decide that this patient needs, what other consults may be needed. Does he need a respiratory service consult? Does he need other hematology consults? At the time, once after surgery, the patient gets in, we get team rounds involving the hospitalist service, the orthopedic service, and the pain team. We round every day together. There's an enhanced recovery after surgery protocols that are done every day on this patient up to the day of discharge. And after discharge, the orthopedic surgery follows this patient. And all of these have allowed for the patient to have a better outcomes. So this model aims at a standardization of perioperative care to reduce the errors that arise from inconsistency of care. This involves patient education, it involves shared decision-making, and allows oriented customized recovery plans and performance targets, which are incorporated at every stage of patient care. So enhanced recovery after surgery did have a little bit like 24 hours or 48 hours prior of patient pre-op, but didn't have this extensive amount of prehab that is involved in the perioperative surgical home. Does enhanced recovery of perioperative surgical home work? And there's multiple evidence to show that this does work. In a retrospective analysis, pardon me, the length of stay for these surgeries, especially for scoliosis, young adolescent healthy idiopathic scoliosis, the length of stay went from an average of 5.7 days to 4 days without a significant increase in readmission rate. So you're not just rushing these patients out of the hospital from 5.7 to 4 days, but there's no real increase in readmission rates. Right now, with the CMS rules and Medicare bundled care, there's a great impetus on getting these patients out of the hospital because there's just a bundled single payment Medicare rate for any surgery. So the hospitals are motivated to get these patients out of the hospital sooner. So with the perioperative surgical home model, there's a significant cost saving on using these models. So it's great there is no increase in readmission rates by following all these standardized protocols. And the overall cost for posterior spinal fusions with patients often exceeds about $100,000. So every day saved in the hospital is a significant cost saving for these patients. And it shows that these ERAS protocols allow about a 33% reduction in room charges. So about $1,000 a day savings and 11% reduction in therapy charges versus the traditional approach. So there is definitely an advantage in going ahead with all these protocols. So here I'd like to share what we do in our hospital with the spine scoliosis protocol. In the preoperative phase, when the patient comes into the hospital in the preoperative setting, they get either PO Tylenol or IV Tylenol. They get pregabalin, celecoxib, and bisacodyl. In the intraoperative, in the OR, it's either an ESP catheter, which is a regional catheter that's placed, or an IV methadone. So the ESP catheter is placed right next to these the instrumentation, and this allows for less amount of opioids to be given. And if the patient is not a candidate for the ESP catheter, then they get IV methadone. And this allows for less IV opioids to be used. They continue on IV acetaminophen. They get dexamethasone and ondansetron. So a multimodal anesthetic regimen is used. On post-op day 0, they get, when they come out into the recovery room, they get a PCA demand dose. And if a ESP catheter or IV methadone is not being able to be used, then they also get a basal dose on the PCA. And the opioid, depending on the patient's allergies, could be either hydromorphone or morphine. They get IV lorazepam as needed or around the clock, depending on patient's anxiety levels or other medical comorbidities. They continue on IV acetaminophen for 24 hours. And if they are able to tolerate PO, they can get pregabalin and stool softeners. The next day, immediately, as soon as they're able to take even liquids by mouth, we start them on PO oxycodone, switch them to ketorolac, and we continue the demand dose PCA till they start PT, switch them to PO acetaminophen, continue pregabalin, continue the bowel regimen, and continue the lorazepam. On post-op day 2, we continue the oxycodone. We add a PRN oxycodone and switch off the PCA so they can be unhooked from all the IV lines. We continue the ketorolac. We increase the bowel regimen in case they haven't been able to poop. And by post-op day 3, the goal is for them to go home. In most times, this is very successful. There's a little switch in this regimen for neuromuscular scoliosis, but it's almost similar to them. And the neuromuscular scoliosis do go to the ICU for 1 day or 2 days because they end up having some respiratory issues. So the protocol is a little different for them. For the NUS procedure, which is for patients with pectus carinatum or excavatum, typically these procedures a few years ago would end up being in the hospital for 6 to 7 days. And these were the procedures that had a high chance or high propensity to have postoperative pain and a almost 30 to 40% chance of having residual chronic pain syndromes. And ever since these clinical pathways have been created, it's now these patients are going home within 48 hours, which is great. And there's less incidence of chronic pain postoperatively for these patients. So we have now created, the surgeons, along with the surgeons in partnership, have created a clinical pathway where preoperatively they receive acetaminophen with gabapentin, celecoxib, they get a scopolamine patch and IV midazolam in the preoperative area. Intraoperatively, the surgeons may do cryoanalgesia. And if they don't get cryoanalgesia, they may get single shot nerve blocks or catheter placements. If no regional catheters were done, then they could get IV methadone along with IV ketorolac, acetaminophen, dexamethasone, and ondansetron. Again, the key here is multimodal analgesia, not just one route of analgesia, but multimodal, which is the key for all these postoperative patients. On post-op day 0, they get Demandos, ketorolac, lorazepam. Gabapentin is continued. They get diazepam for the chest spasms that they may have from this extensive surgery. Post-op day 1, the regional catheters are stopped. They're transitioned to PO medications, and by post-op day 2, they're discharged home. And a typical post-op surgery protocol. So most of our acute pain consultations for post-op pain follow these post-op surgery protocols. So that's our biggest category of post-op acute pain consultations are for post-operative pain management. And we follow a similar protocol for all of these patients. If they get a regional catheter, we continue with the regional block and infusion. We add a PRN. We may or may not add a PRN infusion opioid for them. We continue on a multimodal acetaminophen and an antiemetic for them. We may add a muscle relaxant for them or anti-anxiety medication as needed. We continue on a bowel regimen for them. We transition off the regional in 1 or 2 days, continue with stool softeners and a goal of discharge within 1 to 3 days. And we give them discharge teaching for safe weaning of medications and safe disposal of their opioids. And I'll go further into that in the towards the end of this lecture. We get consults for post-dural puncture headaches, and patients get lumbar punctures that are done in the ED or by neurology for meningitis workups or by neurosurgery for other workups. And patients may present to the hospital with these positional headaches that have happened within 72 hours after a dural puncture. The International Headache Society defines post-dural puncture headaches as a headache occurring within 5 days after a dural puncture, and which resolves within 48 hours after an epidural blood patch, or within a week after a conservative therapy. The incidence of PDPH after spinal anesthesia is generally less than 3%, but can occur in up to 9% of cases. It all depends on the type and the size of needle. In 11% of cases, it occurs when there's a traumatic standard needle is used. And incidence is about 23, with a 23 or 23 gauge Quincke needle is about 8 to 25%. With a 27 gauge Quincke needle, it's about 0 to 14%. And that's why it's very important to use a smaller needle and to maybe go from a cutting needle to an atraumatic needle. And that's why we try to educate our oncology colleagues, our neurology colleagues, to try not to use a cutting needle and to maybe go to an atraumatic needle. With atypical features So where your headache may or may not be positional, where it's lasted more than a week, you want to exclude other causes for these headache, whether these patients are septic, whether they could be infectious causes. For most of these cases, we try to recommend bed rest first, hydration, adequate hydration, at least a liter of fluid. Oral caffeine works, and oral analgesics. Most of these times, these patients haven't even tried this. So get them into the hospital, get them admitted, just give them IV hydration, oral caffeine, and analgesics. In about 24 hours, they start to feel better, and see if that works. For moderate to severe post-dural puncture headache, that's the time you want to consider epidural blood patches. The slide on the right is a patient of ours who had an epidural, who had a post-dural puncture headache after a lumbar puncture, and you can see between those lines the fluid collection. This patient did have to get a blood patch, and the headache resolved immediately and did not return. We also get frequent consults for functional neurologic disorder, also known as conversion disorder. What is functional neurologic disorder? It's a motor, cognitive, or a sensory disorder that can be altered by distraction or a non-physiologic maneuver, which is clinically incongruent with disorders known to be caused by neurologic disease. So there is a known, it cannot be explained by known diagnosis. There is a brain-body disconnect. The brain and the body do not speak to each other. The patient is not malingering. The patient cannot explain it, or the patient is not making it up. It's not a fictitious disorder. A lot of time, patients are frustrated because they have gone to their PCP or the primary care, and the patient is told, or the family is told, that the patient is lying or the patient is making it up. And by the time they come to you, they already don't want to hear about it. But it's now, the diagnosis has changed to now encompass functional neurologic disorder. And there are a number of conditions that come under it. They could be psychogenic non-epileptic seizures. They can be abnormal generalized limb shaking, apparent impaired or loss of consciousness, resembling epileptic attacks or fainting, syncope. So in this picture down there that's shown, Jean-Martin Charcot demonstrating hypnosis in a hysterical patient to his students all the way in 1887. And hysteria as a clinical diagnosis was later replaced by conversion disorder. So this is the first described picture of functional neurologic disorder in the literature. Weakness or paralysis, abnormal movements, anesthesia, mixed symptoms are all under functional neurologic disorder. We changed the name, the nomenclature was changed to functional neurologic disorder in 2013, where it was acknowledged that a psychological, when you call it conversion disorder, it kind of says that it's a psychological stressor, and that is not necessarily always the case. And that's why it was changed to functional neurological disorder. And this new model highlights that a wider range of past sensitizing events, such as physical trauma, medical illness, or psychological, physiological events could be reason for this change. And in the clinical history, it could be an abrupt onset. There's a possible history of a precipitating event, like something could have happened, a recent death in the family, or a traumatic, they could have witnessed something traumatic very recently. In today's teenagers, they could have a breakup with a boyfriend or a girlfriend or something similar, something traumatic to them. There's a fast progression to a maximum symptom severity or disability. Like they woke up one day and now they can't walk, or sudden back pain and they can't now walk. Unresponsive to drugs for organic movement disorders, and the general appearance, they cannot walk or gait transfer. So when you ask these patients to lift they're sitting in a wheelchair, you ask them to lift their leg, they cannot do it. But when you're doing a physical exam on this patient, they cannot lift their leg. But if you ask them to do something, and that does not impact the leg, you ask them to shift in the wheelchair, like to move back, you will suddenly see them use that leg to shift up. That's just because there's a brain-body disconnect. And it's not because they're making it up. They just are able to use that leg when it's not active. And these are all real conversion of functional neurological disorders. It's so many times we see them when we see it in clinic or in the hospital, patients laying in the bed and they say they cannot move their legs. But when you ask them to shift up in the bed, they'll suddenly fold their legs to shift up in the bed, or something similar, where you don't pay emphasis to the part that they say is not working and ask them to do something not related to that part and do not pay attention to what's not moving. And so you will see some movement that gives you a diagnosis. We get consults for sickle cell crises, which occur from vaso-occlusive crises. And these are real crises because pain management is important. Otherwise, these patients can have more pain crises and can have vaso-occlusive or can have chest occlusions. And you want to have a careful history and physical to rule out other causes of pain. We attempt to change meds, escalate doses depending on clinical response of patients. Typically, at least at Stanford Children's, we don't get a huge number of these patients. A lot of them go to Oakland Children just because of the neighborhoods that these patients are in. But the few patients that we do get, they come to us frequently. So first of all, we do a careful history and physical. We figure out what these children have been on and what works for them. We get a rapport with the patient and family. We figure out what has worked for them in the past, and we rapidly escalate doses to what has worked for them. We optimize non-pharmacologic management. We add acupuncture, physical therapy, psychology, psychiatry, and we engage patient and family in the plan till we get a resolution in their acute crisis. And we quickly transition them to the chronic pain clinic so we can keep contact with these patients. It's important to form an alliance with the patient and feel that we are listening to them so that the next time they come, we can quickly incorporate the same plan again. We get consults for mucositis or similar other cancer-related, therapy-related complications from chemotherapy and other cancer-related pain. Like in this patient who had received CAR-T therapy. And as you know, in CAR-T therapy, the therapy causes inflammation at the cancer site. So the extremity had immediate swelling and he had neuropathic pain in that extremity. Just in that extremity, it almost looked like it was a compartment syndrome. And it's difficult pain management in this case because even the amount of opioid management for that extremity was causing him to go into respiratory depression. And he didn't want to use his PCA because that was causing respiratory depression. You could try things like low-dose ketamine, but the hallucinations were not a good side effect for him. A lot of these oncology patients, we try lidocaine infusions, which work well. We cannot titrate the gabapentin or the pregabalin that quickly for medication efficacy. So we try a multimodal therapy again. You can try medications like dexmedetomidine to see, or sometimes they need ICU management. You go to the ICU and you try sedation till oncology works on different regimens and gets the swelling down, either with steroids or other managements. And we work along with our other consultative services to work on this management plan till we get the acute pain down. So you want to complete a careful history and physical to rule out other causes of pain. You assess the pain and change meds and doses depending on clinical response. You can try lidocaine infusion in case it's a mucositis related pain. The pain lasts until there's count recovery. So you have to tamper out either with lidocaine infusions, low dose ketamine, you add gabapentin or similar medications till you get count cell count recovery. You consider opioid titration, and you may add a palliative consult. So you can add significant doses of opioids, and optimizing non-pharmacologic management, massage therapy if available, psychology, psychiatry, etc. We get consulted for functional abdominal pain syndromes and acute abdominal pain syndromes. And we have to do, again, a careful physical history and physical, and get into the causes of acute abdomen. Many times the surgical services are already figured out, whether it's appendicitis or small bowel obstructions, gallbladder disease, constipation. But then we are called to figure out if it's abdominal migraines or functional pain. And in these cases, we then get involved and involve our psychology partners and the psychiatry partners to make a plan on how to manage this best, using either medical hypnosis, biofeedback, CBD. We start medication management and get these patients transitioned to the chronic pain clinic for a good long-term plan, involving acupuncture for a good long-term plan for management of their functional abdominal pain. For headache crises, they're typically managed by medical team initially to rule out vasculitis, stroke code, meningitis, post-dural puncture headache, or other such medical emergencies. Initially, first is considering imaging, if this is a first episode, or if it's a severe headache, or there are focal neurologic signs. The medical team already will initiate therapies, and our role is to consider nerve blocks for these various headaches, like supraorbital nerve blocks, spinopalatine nerve blocks, or occipital nerve blocks, as in the picture here, where the pain team is teaching occipital nerve blocks, and these are our own children that we are demonstrating occipital nerve blocks on. We can try acupuncture, which is works well for symptom alleviation and headache management for these. We get consulted for new onset CRPS and erythromelalgia. So the picture on the left shows a red ear syndrome. Erythromelalgia is a sodium channel anomaly where the ear, nose, hands, and feet can turn intensely red. And the one on the right shows CRPS, or it could be erythromelalgia. Just by the picture, you can't really tell. You need more of a history and a physical. But in CRPS, there's also temperature changes where the hand, CRPS versus erythromelalgia. CRPS is complex regional pain syndrome. There are temperature changes where the hand is cooler than, the hand is red, cold. There are vascular changes, there are temperature changes, and it can happen in CRPS. It can happen after a minor trauma. There may not be any trauma, and it usually follows some kind of a nerve pathway, and it involves intense. It's usually treatment follows a rehab pathway. They do not usually end up being in the hospital for this. We transition them to the outpatient, start medications and physical therapy, occupational therapy, desensitization, and medication. Depending on early management, these can be resolved quickly. And in children, the good news is CRPS can quickly resolve and be treated completely. Erythromelalgia can sometimes be treated quickly, sometimes because this is a familial disorder. It's a sodium channelopathy. They are tougher to treat, but various medications can be tried. We also get medical consults for various different acute and chronic pains like rheumatoid arthritis, JIAs, renal diseases. So we try to determine the type of pain, whether it's nociceptive or neuropathic pains, and accordingly try various other pain medications. We try non-opiates, opioids if they are nociceptive pain, and if they're neuropathic pains, we stay away from the opioids And we try various other co-analgesics like antidepressants, local anesthetics, the NMDA antagonist, according to what the kind of pain is. We also get consults for opioids or benzo weaning. In these, typically from the ICU settings or the NICU settings, we assess vital signs and patient history. We ask to calculate a 48-hour opioid benzodiazepine requirement for these children. And we calculate an equivalent conversion of the medication to switch to. Currently you can use opioid calculators like Practical Pain Management, which has these opioid calculators as needed. And you always want to consider cross tolerance to any opioid that you want to switch over. On the pain service for children especially, we reduce opioids to at least 20%. In adults, you can reduce to 50%. And for vulnerable preterm or full-term infants, we will reduce to 5 to 10% at least. And we risk assess for withdrawal. For continuous opioid infusions that have only been less than 7 days, you can discontinue infusions without requiring a taper. For patients receiving opioid infusions for greater than 7 days, we could just taper gradually to prevent withdrawal. For higher doses of opioids or infants who have been exposed previously to opioids or have been on multiple sedative medications at the same time, you may want to taper gradually and consider adding an adjunctive agent like clonidine or methadone, or add other multimodal techniques or non-formulary techniques like massage therapy, acupuncture to help with wean. At the same time, you also want to add WATCH scores, which is withdrawal scores, and NAS scores, which is neonatal agitation scores throughout to monitor your withdrawal. We also get consulted for acupuncture. I have this story about my own dog when his first July 4th, and he was very jumpy and I was not sure how he would take. And I did acupuncture on him, and there's that needle on the left. Did it about 2 hours prior, and as the fireworks came around, he stood at the window, just looked out and watched. And ever since then, he watches fireworks now and he has no problem. He just doesn't go out. If he is a very jumpy dog, and he jumps even when he sees squirrels and the fireworks are right next to him. But if he's inside the house, he feels very secure. So I think acupuncture works. There's a lot of evidence that acupuncture works. And acupuncture works for nausea, vomiting. It definitely works for sedation. We get a lot of consults from the ICUs to help with sedation, weaning, to help with babies who are not sleeping. And feel free to send me an email if you want specific protocols. There are courses for physicians to help to learn about acupuncture. It would be remiss of me to not talk about the opioid epidemic and how we can help as medical professionals to reduce the opioid epidemic. And this is from the HHS. About just in 2020, the opioid epidemic has kept increasing. And there were 3 waves of the rise in opioid epidemic. And this is from the CDC. The first wave began by increased prescribing of opioids in the 1990s. And this was by involving prescription opioids. The second wave began in 2010. And this was by rapid increase in overdose deaths involving heroin. And the third wave began in 2013 by illicitly manufactured fentanyl. So we've gone through 3 waves of opioids. And what is our role? Is we can reduce this wave of opioid overdoses, because as we know, teenagers and young adults are exceptionally susceptible to opioid overdose because they have all these opioids that are easily available to them. We send them home with opioids, and if these are not locked up or kept safe, they may be bad repercussions. So we want to, when you send patients home from the hospital on opioids or benzodiazepine, you want to discuss weaning of these medications, safe storage and disposal of controlled medications, prescribe reversal agents, opioid antagonists, naloxone spray if needed. Always talk about DEA take-back programs, or where they can take them to whatever leftover opioids, you can always take it to your nearest pharmacy that can take it back. Sometimes it's a CVS or a Walgreens close to them. There is once a year, the DEA has take-back programs once or twice a year. There's a don't rush to flush, which also has how you can dispose of your medications, like putting them in, crushing them into coffee grounds and then flushing them into the sink, or other safe ways if you can't take it back to a pharmacy. And the CDC has some strong infographics on how to reverse opioid overdose with naloxone. This would help in preventing the stem of the opioid epidemic that we are currently in. Thank you. And I would like to end with saying Happy Father's Day to all the dads out there who make it possible for moms like us to keep it together. And no pets or children were harmed in the making of this lecture. And the pet used for all the demonstration was just mine.
Excellent. Thank you so much for that lecture, Dr. D'Souza. I think great way to end that lecture. I do have a few questions that have come in through the Q&A, and so I'll just go through each of them.
Excellent. Thank you.
So the first question is, I'd like to know your suggestion. What is better to use? I'm thinking this is LZ's fear of pain or needles prevention in a regular pediatric office. So so what's better to use for fear of pain or needles prevention in a peds office?
Yeah. So I would say the first thing would be to ask the child what works for them. There is Buzzy, which is a device that can be used over the site that has like a distraction that can be used. I want to pull out, there's a website on the Stanford pain website. Stanford did come out with a video on don't fear pain on needles. And if you give me a minute, I can pull up the video. And it's a great video. Sorry, I should have kept it available, but there is a video that they came up with on how to don't be scared of needles.
Okay, that's great. We can, while we're talking, we can look at that and see if we can get the link and put it in the chat for the attendees.
Yes.
The next question is, at what age do you start to use gabapentin? What dosage by kilo or age? And this person said they were always taught to start low and go slow. Do you agree?
I do agree. We start at any age. We don't have an age limit. Typically, we start maybe about at age 6 months or so, I would say. We've started younger than that, but that's in the hospital setting, not in the clinic setting. We start by kilo. Dosing is by kilo. It's 5 milligrams per kilo. And our max is 50 milligrams per kilo.
Great, excellent.
But yeah, we do, sorry, for dose changes, we don't change a dose. We go like every 3 days or so.
Okay, next question. How to treat FND, functional neurological disorder? I feel like that might be a long answer, but we have time, so.
How to treat functional neurological disorder? Excellent question. That is an excellent question. The first thing to do is get partnership. The first thing is to explain the diagnosis with the parent and child. It's a partnership. Once the parent and the child understand the diagnosis, then you need a team-based approach. You need physical therapy, you need psychology, and maybe psychiatry, and the patient and the family to work together. Many times, It's about participation together, and maybe you need a rehab-based approach, but it's mostly physical therapy and psychology-based approach. The role of the medical professional is less. It's more about psychology and retraining the brain to process the signals from the body.
Okay.
And a lot of physical therapies out there have a protocol for this, where they work slow, but they work with the patients to get them to understand these signals. Virtual reality is great, where they work with these patients with virtual reality, they get them engaged, and when they're gaming, it's distraction, and then suddenly they realize, oh my God, my body does move.
Wow, that's exciting.
Yeah.
To see the applications of virtual reality in this setting as well. Next question is on post-dural puncture headache. What do you mean with oral caffeine, coffee or tablets?
It can be both. Initially, you can start with oral caffeine. We tell patients you can have, if you like, you can just have coffee. You can have caffeinated sodas. And we tell, if they're young children, we say, and one of the treatments of headache is also to sleep well at night. So we say it's a hard stop not to have coffee after like 4 or 5 at night, so they can sleep well at night, right? Because that is also important. So we say stop it like 4 or 5 at night and continue hydration. And then if that does not work after like 12 or 13 hours, then you start with caffeine tabs, about 500 milligrams twice a day.
Fantastic.
And you can send children home with the same protocol. They can have caffeinated sodas or drink coffee if that's what they prefer, or you can supplement with caffeine tabs.
Next question from an attendee who wants to know, does AP, I'm thinking this is acupuncture, does AP work well with cancer-related pain or nausea?
Excellent question. Yes, acupuncture works very well with cancer-related pain and nausea. The only caveat is they need a good functioning platelet count, because if you're going to do any kind of needling, you don't want to cause more petechiae and trauma. Then you have to move to acupressure, which is placing these magnetic beads on them. But even then, it's more about having a goal with the parent. If the parents are okay, if it's more like a palliative goal and they're okay with a little bit of bruising, then you can continue with acupuncture. If they're not okay with bruising, then you want to do just placing the acupressure. But yeah, in the hospital setting, we do acupuncture. Many times, the ones that are hospitalized don't have a great platelet count. That's why they're in the hospital. So we just do acupressure, or they're being admitted for sepsis rule out. So we just do acupressure in the hospital. In the clinic setting, we get a lot of patients who come to us for nausea or pain, and those patients all get acupuncture. Fantastic. And I can do a quick education about acupuncture for nausea since we are all here. You would just go down this between your two tendons where your finger stops, and if you put pressure on there, that's your P6, which is your acupuncture for nausea point. And if you rub on that, that should help with nausea. So you can tell your patients with cancer pain or just regular motion sickness and acupuncture, if that's what bothers you, you can just press on these bilaterally, and that should help with nausea for acupuncture.
Oh, that's great. Such a a short tidbit on how we can utilize it. That's fantastic. So I have one more question in the Q&A, and so I'll just encourage people, if you still have any burning questions, please go ahead and put them in now. And so the last question is about recurring headaches. What is your input in treating them with electrotherapy like TENS or any other type of electrotherapy?
We do use electrotherapy for headaches because a lot of these recurring headaches are from tension headaches. And so the electrotherapy does allow with relaxation of those muscles. And that helps with relieving some of the pressure from these headaches. And there are many other similar devices that have now come out in the market. Some of them are approved more in the adult population, so you may get pushback from the insurance companies to approve these. So there's Cetlali, which is Cetlally. And we have gotten approval for some young adults, 16 and above. That is also similar to like a TENS unit that you apply on the forehead for those who have frontal headaches. For the TENS unit, that's now over the counter, and you can get a really good TENS unit that's under $100 over the counter. You can get them from Amazon or even from any of the Walgreens, CVS kind of pharmacies. But all of these are great electroacupuncture kind of devices, TENS units, that are very useful because they do help in relieving the pressure. They allow like a little massage therapy, and the patient can do anywhere, right? Because one of the biggest stressors for frequent migraines or headaches is school or societal stress, because these kids these days are such high performing stress situations all the time. Maybe we were in the same stress situations. I don't remember being under such high performing. We were not in this culture where we had to excel in school, excel in sports, excel in art, excel in music. We didn't have this much of pressure, and our kids have extreme amount of societal pressure these days. And so they have to, somehow the stress all has to come out, and they hold it all in their shoulders and in their head and in their belly. So everyone has a different way of expressing their pain. And so the TENS unit does help.
Okay.
If you give me a minute, I'm going to find that video for you guys.
Okay, was it the what was it called? The do not fear, or learning how to manage pain during medical procedures?
Yeah, exactly.
Okay, yeah, we have that link. I'll put it, we'll send it to the attendees right now.
Yeah, that was created by Dr. Jodie Thomas, who was a psychologist with the pain clinic. And she created it specifically for the hospital to help with things like immunizations, vaccinations, and that can be used to help your children not fear with pain. And then Dr. Christine Chambers, also up in Canada, has created something similar that can help with vaccination pain.
Excellent. We'll get that out to the attendees right now. And then another question came up. What is your process for the treatment of breakthrough pain in children with cancer? And in your experience, what would be the preferred medication for it?
For breakthrough pain in cancer, it depends on what is the reason for the breakthrough pain. And what is the oncologist's reasoning with the breakthrough pain? Is it poorly managed pain, or is it new process, a new expansion of the disease process? And is it expected to be more chemotherapy, more radiation, or is this going towards palliation? So what are the goals for the family? Because some of the families don't want their patients to be more sedated. They don't want the patients to go home on opioids. They want them to be awake. Some of them would they don't mind their patients going on more their children going on more medication. They want them to be comfortable. So you have to first engage the family, find out what the goal is, and you want to figure out what the goal is with the team. Once you have that all figured out, the goal could be multimodal again. Every time it's the same answer. It's always multimodal. So you start a non-opioid, and then you start an opioid. So the non-opioid, you would recommend acetaminophen. You would, if allowed, you start a non-steroidal, so either Celebrex or ketorolac, if it's allowed. And then you add a gabapentinoid, if that's not already on board. And then for the breakthrough pain, you need some amount of opioid always in these cancer patients. And depending on how quickly the pain comes, it could be either sublingual morphine, it could be a fentanyl lollipop, it could be a patch, it could be just a tablet, an oxycodone rescue. So we have to figure out how quickly the pain comes, how quickly can what works. So many times these patients have to be admitted. You figure out you first give them a PCA to figure out how much is their requirement in 24 hours. And then we either switch them to a PO regimen or into an IV regimen or a patch regimen, depending on what their requirement is. Sometimes in these cancer patients, we just request that they get admitted so we can figure out what their 24-hour requirement is. And then we transition them into an appropriate, similar regimen that can keep them comfortable.
Great, thank you for that thorough response to that. Lots for our attendee to kind of think through. The next question is, in patients with chronic pain, do you come across many that have a family history or family system involving chronic pain?
Yeah, pain can be familial or genetic. There can be genetic unresponsiveness to medications. Pain can also be societal, as in it can be multiple reasons for pain. There can be a hereditary reasoning for pain, like they could have sodium channelopathies and similar reasons for pain. And that's why when we interview these patients, it's a chronic pain. We interview not just the patient, we also have the psychology interview with the family. We find out all these reasoning. We find out what works for the patient. We also find out if there's a history of pain in the family and what works for the family, so that we can incorporate everything together. There's pain catastrophizing. If the parent tends to catastrophize pain, then the child is probably going to catastrophize the pain. So you need to work on the parent as well as the child to be able to manage pain appropriately.
Great. Thank you for that response. I think you commented on this a little bit earlier, but an attendee wants you to expound on it further about your input. What is your input on management of pain due to vaccination?
Yeah, so management of pain due to vaccination. Like I said, I would refer to Dr. Jody Thomas's video and to Dr. Christine Chambers has a website where they talk about no needless pain. In my own experience, what we do is setting expectations in the younger children under the age of, you can put ice the area before you go in. So you can numb the area using ice. Distraction works. Breastfeeding the child as they're vaccinating, so that also works.
Fantastic.
Those are some of the simple strategies that can be used. Okay. In older children, you can ask what works for the child. The children usually can tell you what works. They sometimes say count to 10, or don't tell me don't tell me at all, just do it. Sometimes the children will tell you that I want you to ice it. I want you to let me play on my phone while you do it. It's usually a partnership.
And I think that's kind of, in listening to you responding to some of these questions and recommendations, I think that's one theme that has come through for me. It's that either partnership with the child, a partnership with the parent, a partnership with other specialists in helping the patient with their specific pain situation. I think that's been a thread that I've noticed in your responses.
Yeah, even in the hospital, they give you a paper. Now, when you get admitted, they'll give you a paper where you explain what is your pain plan, right? So they ask you what has worked for you in the past, or what would you like when your child's IV started. So sometimes you can say, I would like my child to have a numbing cream placed 15 minutes before they start an IV. Or don't use that IV numbing spray. We have the numbing sprays now, and they're like, don't use a numbing spray. It scares my child. So they have a pain plan that you can list. So those things, like, you want to be able to list all of that even before.
Okay, good. One last question from the attendee asking for more resources. Do you have any good resources on acupressure for headaches that you can share?
Resources for acupressure. I would ask.
Yeah, go ahead.
I would ask the attendee. I have to think about that one because I know there are some on the websites, but I just don't want to list them because I haven't looked for it personally myself.
Fair enough.
If you go to the medicalacupuncture.com, there may be some listed on there, but I haven't, or Yin Yang House might have some listed, but I haven't really filtered it and be able to tell you, yes, this is a good one, because I haven't looked for a long time. But if they, feel free to send me an email and I can send you back specific ones which I think are great for acupressure. For acupressure offhand, what we typically say is where the web, sorry, I'm not showing, on the web of your hand, if you press right here, that's usually a headache point. And then this one, right, which is your third eye, which is your blind spot, which is called the third eye. If you press on this area of your forehead. So if you press like this and this, they can press these areas. Right now, I feel like a headache coming because I've been prepping for this and I've been a little stressed. So just pressing on this right now for the lecture, towards the end of the lecture, I'm feeling quite relieved and stress-free. So pressing on these 2 points, pressing here seems to help. So these are easy acupressure points, but Yin Yang House, medicalacupuncture.com, or feel free to send me an email and I will be happy to send you some links.
Okay, it seems like every time I say last question, another question pops up. So I'll keep throwing it at you until we're at time. Question in the chat is, any input on opioid dependence in children?
I want to say it in a very kosher way, so I don't set off any of the attendees. Opioid dependence in children can happen when they're on opioids for longer than 7 days. And when they're on long-term opioids, I did participate in a paper that you can find in Children, where we've talked about opioid dependence that was published in Children, in the journal Children's. And sorry, I don't have a link very easily, but I'm sure Ruth will find it while I'm talking. There's part 1 and part 2 about opioid weaning and dependence. But in these cases, you use a multimodal technique for weaning of these children. And typically we use medications like methadone, or we use a slow wean and use adjunctive medications like clonidine and other sedatives like Ativan to help weaning these opioids. Does this help answer the question?
Yeah, let's give that attendee who asked that question an opportunity to type in a comment if they had an additional way to clarify, or whether that answered.
And the paper that is published in Children's, if you put my name.
Yeah, I think I found it. So it's a pharmacological strategies for decreasing opioid therapy.
Yes, and there's a part 1 and part 2. Part 1 was with explains dependence and everything. So that has all the strategies behind it.
Excellent. Yeah, just putting that in the chat for the people, for our attendees to see right now. Okay, I think that while we're waiting to make sure that that answered the attendees' question, I think my last question that I'll pose to you is, you talked about a lot of different scenarios, but how would you synthesize for our attendees kind of what they can take away from the session? Like, if you had a key takeaway for our participants, what would you like them to walk away with?
I would like them to walk away with the understanding that we at the pediatric pain management team are always available 24/7 for any consultations. We have given some strategies. I'm a representative for a team today. They are always welcome to use the strategies that I've described, but feel free to reach out to us if they have any questions. We see some very complex conditions in our hospital because we are a tertiary referral center. But I think all our partners here, all our tertiary sites do a great job, and we don't see as many patients because everyone out there does a great job in managing pain.
Great. Thank you. Thank you so much for that. I appreciate how you synthesized and wrapped up by saying kind of we're all in this together, everyone's doing what they can, and that just that openness to collaboration. And I got a note from the same attendee who asked the question. Seems like I think that you answered their question, so that's great. I see that you're typing in an answer about pain consults, and the answer is yes.
Yeah. So there are pain consults available. I also practice in the outpatient pain clinic, and we have pain consults available. Our clinic is staffed. We have sites in Sunnyvale, Menlo Park, and Emeryville. So we have South Bay, East Bay, and Menlo Park. Mm-hmm. And we have providers there, multiple providers all day of the week. And they are all multidisciplinary. So our new consults are with psychology and some days of the week with physical therapy. And so you feel free to send us a consult through the Stanford system and they get to us.
Fantastic. I think with that, we'll wrap up. And I just want to say, thank you so much, Dr. D'Souza, for, spending time with us this Friday afternoon. For our attendees, she was on sabbatical, but she turned up for this session. So thank you so much for sharing your insights with us on this topic and for an excellent presentation. I also want to thank our attendees who have maybe showed up for this session for the first time or have been with us throughout the week. It's because of you that we are so excited to put on these types of virtual conferences and education sessions. So thank you for your participation in today's session. I also want to let you know that we do have more pediatric focused CME offerings. So feel free to go to lpchcme.stanford.edu and check out all of the incredible efforts that our experts here at Stanford are doing and that are available to you at no cost, really. So with that, thank you for participating, and we will, I hope that you have a great rest of your weekend. Thank you.